Good afternoon, everybody, or is it good morning? I don't know. This is a recorded session. I'm Dr. Sean Favell, and this is the teaching for evidence-based medicine for the middle grade group at Lincoln County Hospital, A&E. So today, I believe, is lecture 3 on evidence-based medicine. It's the final lecture before we start talking about critical appraisal. So I'm going to have a quick recap of the last 2 sessions on evidence-based medicine and then get on to the final bit. So you'll remember we started talking about evidence-based medicine. We discussed what evidence-based medicine is. And we discussed that it was the meeting of 3 different things. That's best research evidence, clinical expertise, and patient values. We also discussed that there were 4 different steps to evidence-based medicine, the 4 A's, where we ask a clinical question, we acquire the best evidence, we appraise the evidence, and we apply the evidence. And you'll see those 4 steps coming up a little bit later on too when we talk about systematic reviews. And the quote that was in the BMJ in 2008, a 21st century clinician who cannot critically read a study is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. So I think that quote from the BMJ suggests that evidence-based medicine is intrinsic and is a principal part of medicine. We discussed why we need evidence, and I told you the story of Dr. Benjamin Spock, who in his 1958 edition of Baby in Childcare had made the suggestion that parents should sleep their children in the prone position just in case they vomited to prevent them from aspirating. But then later research that was done 31 years later by Peter Fleming found an association between babies sleeping prone and cot deaths, which we call sudden infant death syndrome, SIDS. And because of that, there was a Back to Sleep campaign in 1991 asking parents to ignore Dr. Spock's advice to sleep their children prone and to sleep them in the supine position. And we know because of that campaign, in 1989 there were 1,500 cot deaths before the campaign, and now there are less than 300 cot deaths per year. So potentially 1,200 cot deaths were happening per year because children were being placed prone in their cots. And the moral of that story is what seems very logical to us as scientists can often be quite harmful. So a little bit of a red banner there. Non-evidence-based practice can do a great deal of harm, even though the practitioner is highly experienced and has the best motives. I showed a few examples of test treatments and procedures that have been shown to cause more harm than benefit. We touched on bias briefly because that's important later when we look at studies and trials. Bias being a disproportionate weight in favour or against an idea or a thing. And there are several forms of bias. I also talked about bandwagon effect. That's something we suffer from a lot in medicine because our colleagues do something or have shown us how to do that. We all do that, where in actual fact we could all be doing the wrong thing, but we all do it together using the bandwagon effect. So we went on to talk about best research evidence. We talked about the best and the worst types of evidence. We had a quick look at the evidence pyramid. The bottom of the pyramid, there is more of things like expert opinion, but it is weaker than things at the top that there are less of, but are more powerful, such as systematic reviews. We also talked about filtered and unfiltered information. Unfiltered evidence being case control studies, cohort studies, and randomized control trials. We talked about expert opinion, saying that you find it everywhere. It seems to be the go-to for doctors, but in actual fact, it's the least valuable. So I always tell people everything that you're told to do by somebody else, take it with a pinch of salt, even if it comes from me. Go and look up the evidence, because you'd be surprised how many times an expert will be very wrong about something. Okay, we talked about case control studies, which again are unfiltered information. We talked about that case control studies are observational studies, And observational studies are studies in which the subjects are not randomized, into exposed and unexposed groups. The subjects are observed in order to determine their exposure and their outcome status. And the exposure status is thus not determined by the researcher. Case control studies make studies between cases and controls to identify factors that may contribute to a medical condition or outcome on the basis of a supposed causal attribute. And we also mentioned that case control studies have a statistical entity called an odds ratio, which is different to relative risk that we find in cohort studies, which is a different kind of study we will talk about soon. Now, we gave an example of that a observational study here, a case control study, was based on the hypothesis that smoking causes lung cancer. We had cases being people with lung cancer. We had controls, which is people that didn't have lung cancer. And we had an exposure, which was smoking. And then we looked at the population or the numbers of people who had lung cancer who had also had the exposure of smoking. That's how we do a case control study. But there's problems with case control studies, and the biggest problem being selection bias, and the other problem being confounding. We talked about confounding. We talked about the fact that if you do studies on people who drink alcohol, you'll also find that people exposed to alcohol are also more likely to have lung cancer. But alcohol does not cause lung cancer, so it's confounded. In actual fact, people who drink alcohol are more likely to be smokers and therefore more likely to get cancer. So confounding is a very important factor when we're looking at case control studies. The next form of study, again, are cohort studies. What they do is they follow a cohort of similar participants who share common characteristics, such as a particular occupation or demographic similarity. Some of the cohort will be exposed to a specific risk, but that's not selected by a researcher. We're just studying a naturally occurring exposure or risk. And we watch this study over time. We watch how the exposure affects the people who are exposed, and we look at the outcome or the event. It can be prospective, so we can look at something happening. We can start the study now and look at what happens in 10 years' time to people that are exposed to a certain exposure, or we can look at it retrospectively. We can look at people who were exposed over a period of 10 years in the past. Cohort studies, the statistical measurement that they use there is relative risk, not the odds ratio that we mentioned before for case control studies. Again, common problems with cohort studies are selection and allocation bias, and again, confounding. So you'll notice that when it comes to these studies, when it comes to case control studies and cohort studies, the problem that those studies have is confounding. Also with cohort studies, it's got a limited benefit in rare diseases. So even though statistically cohort studies are better than case control studies, cohort studies aren't a great deal of benefit in rare diseases because you're unlikely to see a rare disease manifest itself in a cohort unless you're looking at an extremely large cohort. So for example, I looked at a cohort of people from Lincoln County Hospital with the exposure of doing night shifts to see if that increases your risk of leukemia. But because leukemia is a relatively rare disease, you're unlikely to get any cases or any events. So it's not a very good study for those kind of things. You're better off doing a case control study where you look at people who have got leukemia and have a look at any exposures that they've had. That would be case control. So the next kind of unfiltered information or unfiltered evidence is randomized controlled trials. So you look, we've got the studies and we've got the randomized control trial. Randomized control trial is an experiment, it is not a study. So with the studies, we're observing something. Those are observational studies, but with randomized controlled trials, they're trials. We're actually doing an experiment. When we do trials, it allows far more statistical control to overcome population variations and confounders. So we can structure these trials. And what we usually do, typically in a randomized control trial, is compare proposed new treatments against an existing standard of care like a control. We also have blinded and double-blinded trials where the people being studied don't know what treatment they're getting and the people who are studying them don't know what treatment they've had. The result of that is that reduces bias and confounders. So randomized control trials are the gold standard for clinical trials because they have a lot less bias and confounding in them. So that's where we got to with the last lecture. And we've finished with unfiltered information and we're about to go on to filtered information. Now, what's the difference between filtered and unfiltered information? Well, basically, filtered information means somebody or some group or some entity has filtered the information from those segments lower in the pyramid and have done something with all that evidence and formulated an opinion. And the first one on the list of filtered information is critically appraised articles. Now, important, see the flashing arrow? Critical appraisal. Now, we're going to start introducing this term because at the end of these lectures, I'm hoping that you'll have the tools to be able to critically appraise articles for yourself. And even critically appraise the critical appraised articles and the rest of the evidence. But right now, it's been done for you. So the next highest level evidence is critically appraised articles, where somebody else has critically appraised those articles. Now, what is critical appraisal? Well, that is a systematic process that's used to identify the strengths and the weaknesses of a research article in order to assess the usefulness and the validity of the research findings. The critical appraisal allows us to reduce information overload by eliminating irrelevant or weak studies. So this is part of what will happen in the critical appraisal. They will identify the most relevant papers. They will distinguish evidence from opinion, assumptions, misreporting, and belief, which is mainly what you tend to find out there. That's what most of the public are being exposed to, particularly on social media. And that has no place at all in evidence-based medicine or science. We also there assess, or the critical appraiser will assess the validity of the study. They will assess the usefulness and the clinical applicability of the study, and they will recognize any potential for bias. So a good critically appraised article will attend to all those points and will be honest about them. Now, you can probably surmise there, critically appraised articles can be prone, if they're not done very, very well, to the biases of the people who are critically appraising them. So as I mentioned, we will discuss critical appraisal more fully in the final lecture, which is the next session, which is really what these lectures are leading on to. So the next filtered information are critically appraised topics. Now again, critical appraisal. So these are critically appraised topics, or sometimes we call these CATs. These are short summaries of the best available evidence on a focused question. Now, if you remember at the beginning when we spoke what is evidence-based medicine, we talked about questions. Well, what's important with CATs is we start to focus on a question now. It's a shorter and less rigorous type of a systematic review, which we'll get to very, very shortly. And it provides an assessment of what is known about an intervention or an issue by searching and appraising the relevant studies. So these are short summaries looking at the best available evidence from multiple but relevant studies to try and come up with an answer to a particular question. And that question, for example, could be, is metformin the most effective first-line treatment for diabetes? That could be your question. Now, right there then at the top of the pyramid is systematic reviews and meta-analyses. Now, these are the gold standard. Systematic reviews are the very top of the pyramid. Systematic reviews differ from meta-analyses, but often the two go hand in hand. A systematic review is a qualitative research synthesis. So what we're doing there again is we are doing a scientific investigation that focuses on a specific question and uses explicit and planned methods to identify, select, assess and summarise the findings of similar but separate studies or trials. It may or may not include quantitative synthesis of the results from separate studies. Quantitative, that's what we do in meta-analysis. So the difference between systematic review and meta-analysis is one is qualitative and the other is quantitative. In a meta-analysis, the results of a number of randomized clinical trials or observational studies may be statistically combined to obtain a summary estimate for the effect of a given treatment. And we'll show you some of that very, very shortly. It's important to know that systematic reviews and meta-analyses should be differentiated from other less data-driven review articles in which authors present their own interpretation of data. So there are 5 steps to a systematic review. So the first step is you're going to formulate a question, and as I suggested before, that question could be, is metformin the most effective first-line treatment for type 2 diabetes? The second step of a systematic review is the studies will then be searched for that are relevant to that question. Then there'll be an assessment of the quality of the studies that it's been included, and there might be some exclusion criteria to try and improve the quality of those studies. Step 4 then will be summarising the overall evidence that you've got from those studies that have fallen into that particular search criteria, and then you would interpret the findings and present those in a conclusion for a systematic review. Meta-analysis, as we mentioned, is the process of using statistical methods to quantitatively combine the results of similar studies identified in a systematic review in an attempt to allow inferences to be made from the sample of studies. So this is a mathematical, a statistical analysis rather than discussing what's been found. The strength of meta-analysis comes from it being an analysis of combined results from multiple studies. So we're looking at the results of several different studies, thereby increasing the power to detect differences between these studies and look to see if there are any common trends. So meta-analyses can be prone to publication bias, though, because some of the studies, particularly studies that have less significant results or studies that are actually not written in English, are less likely to be published, and because of that they kind of get missed from the selection criteria and don't end up in the analysis. So there is some selection bias to meta-analyses, even though it's up there at the top of the pyramid. So it's important to know that. So just play you a quick video then. It's no good talking about systematic reviews when somebody's already done this a little bit better than what I'm doing at the moment. I will apologise for the overuse of the word data. It sounds like the narrator is Australian. It's not come from an Australian site, but the narrator here is Australian, and for some strange reason they call data. It drives me mad, but it used to drive me mad when I lived in Australia. But nevertheless, don't let that spoil the video. We'll play the video.
What are systematic reviews? Systematic reviews help make sense of many kinds of data. They're a way of reviewing all the data and results from research about a particular question in a standardised, systematic way. A systematic review helps give an objective and transparent overview of all evidence surrounding a particular question. The Cochrane Collaboration logo visually represents how results from some systematic reviews can be explained. Here's how a systematic review works. First, a question must be defined, and an objective method for asking the question is agreed. Imagine a circle as the area defined by a question. Everything inside it concerns the question. Everything outside of it does not. In this circle, relevant data will be included. A search for relevant data begins. This data can come from many sources, including data from clinical trials. Imagine the shapes represent data sets from different research, for example, different clinical trials. The data set must be the right shape to fit. Only data from research that matches certain criteria can be included so that the results are reliable. For example, selecting research that is good quality and answers the defined question. If the research meets the criteria, more detailed information about the research can be collected or extracted. Information extracted can include how the research was done, often called the method, who participated in the research, including how many people, how it was paid for example, funding sources, what happened, the outcomes. This information is judged against criteria in order to assess the quality of the research. Once the information is extracted, it can be combined using complex statistical methods to give an overall result from all of the data. This circle is one way of representing this data visually. It's called a blobogram or a forest plot. The area of inquiry, defined by the question, can be divided into a yes and a no half, a positive and a negative side. The shorter the line, the more confident we are of what the data is telling us. Think of a longer line as less focused and scattered data, and shorter as more focused and bunched. Imagine knowledge as light and ignorance as darkness. The more spread the focus of the light, the weaker it is, and the less clear things are. If the light is focused and data is grouped more clearly, we can be more confident of what we see. The diamond represents the combined results of all the data included. Because this combined result uses data from more sources than just one data set, it's considered more reliable and better evidence. The more data there is, the more confident we can be.
That's it then. Thank you. Very sorry that I had to bring you this by video. Next session will be on critical appraisal. Hopefully it will be me live rather than doing it by video. But thank you very much for those who made it this far. Those of you who didn't make it this far, well then, shame on you. Shame on you. And I'll see you very soon. Bye for now.